So in disclosure, hi, nice to meet everyone. Sandhya, Panch. Flew here, took the red eye from Seattle, Washington. A little bit of background about myself. I trained at the NIH, at the National Heart, Lung, and Blood Institute in hematology and transfusion medicine before moving on to doing clinical work at the NIH for 10 plus years before moving to Seattle, Washington, where I've been for the last year, mostly seeing patients with ITP, warm autoimmune hemolytic anemia, and cold agglutinin disease. My interests are primarily in the translational research space, which is I see patients 1 day a week, and the rest of the time I spend doing research regarding mechanisms of origins of these diseases, both from a transfusion medicine standpoint as well as hematology. So happy to answer any questions. This is your meeting, and so I'm not going to grab the limelight here. I would like to, try and give you brief overviews. You are better, equipped to understand and know these conditions than I am, if anything, and would happy to open it up for questions, and we can make it an interactive discussion if that's okay, Karen. Yes. So I don't have anything formal prepared. I'm normally a slide person, as I was telling Dr. Reena here. So just briefly, all of you in the room, or many of you in the room, are familiar with autoimmune hemolytic anemias. This is a condition where your body generates antibodies. Your body makes antibodies against your own red cells. And we often, I would say about half the time, we don't know why this happens. It's just what we call idiopathic. And I always tell my patients, idiopathic, physicians use the term idiopathic because, it's almost like you're deriding the condition, saying it doesn't know what it's doing. It's actually the physicians who are idiots in some ways. We don't know why it happens. That's the well-kept secret, by the way. So when you ask them a question, they're like, yeah, and this and that, but actually we don't know. Okay, that's the real answer. So, we try to be, So, and that's the piece actually that I'm interested in, the whys and the hows and the, why nots and so forth. So, would love to hear your stories, of course. I was just chatting with a gentleman here who had a very interesting take on a particular new drug, which seems to have helped. So it's very interesting to hear your thoughts on these, on your personal experiences. So anyway, these are antibodies that are made by the body against your own red cells. How crazy is that, right? And as Karen mentioned, the rarity of it, 1 in every 100,000 patients, and then with cold agglutinin disease, it's 1 in every million or so. And these are similar yet different, and I'll start by mentioning some of the similarities, which is both for warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. As the name suggests, the autoimmune phenomenon occurs in both conditions, which means there are antibodies being produced against your own red blood cells, okay? And then the anemia occurs in both, okay? There's wAIHA and cold agglutinin autoimmune hemolytic anemia. There's anemia in both conditions, which is what most people present with: extreme fatigue, dizziness, unable to just carry out your daily activities. The warm and the cold is really, the names come from the fact that the anemia itself, or the antibodies, it depends on what temperatures the antibodies stick to these red blood cells at. If they stick to these red blood cells typically at body temperature, that's considered warm, okay, typically. And then if they stick to your red blood cells when it gets colder, okay, for instance, you're not wearing gloves in Minnesota, on December 24th, and then you see really red swollen fingers or extremities, for instance, right? That's basically because your fingertips are so cold that there's red blood cells which are circulating that are there, they sense the cold, and then there are antibodies actually that sense the cold and bind to the red cells, which cause some of the symptoms that are characteristic of cold autoimmune hemolytic anemia. Okay, so the temperature at which these antibodies bind gives them their typical name. And what happens is when you come in, or when people come into the hospital with anemia, there's obviously a whole slew of different things it could be, right? So what physicians typically do, they check your hemoglobin, they check your other blood counts, is your white blood cell count okay? They're typically okay, whether it's warm anemia or cold anemia, unless there is an underlying problem. If there is a leukemia or a lymphoma or something that's causing it. Sometimes lymphomas can result in these conditions, in which case there might be abnormalities in your white blood cells. Then there's platelets, okay? Platelets are also typically normal in warm as well as cold autoimmune hemolytic anemias. Occasionally though, your platelet counts may be low in a condition called Evans syndrome, which is basically a combination of warm autoimmune hemolytic anemia, much less frequently cold, and ITP, or immune thrombocytopenia, which means there are antibodies that are being produced by your body not only against your own red blood cells, they're also being produced against your platelets. Okay, and that's a condition called Evans syndrome. Okay, so when physicians, as soon as you come in, they review your complete blood count. These are the things we're starting to look for. Okay, that's the first piece. And then we go on to asking the question, is there hemolysis? Okay, because that's in the name, right? So then we look at your blood smear and say, are they all fragmented, which can take us down a different path? Or do they look completely full? Are they clumped? Those are the things we look for when we look at your blood smear. That's another important piece for us for diagnosis, okay? And then once we have this information, we send off additional laboratory tests. And here we look for, is there markers of red blood cell breakdown, okay? And some of the important markers are things like LDH, which is lactate dehydrogenase. This is an enzyme that's present in red blood cells in various other types of cells also, but a lot in red blood cells. So when they break down, there is release of lactate dehydrogenase, which you can then pick up in the blood. So that's actually an important marker when you see it going up. In addition to some other things, you want to start worrying about hemolysis or red blood cell breakdown, okay? So even with LDH increases, there's also other things that you want to look for. Haptoglobin is another one. It's an enzyme that binds any free hemoglobin, circulating hemoglobin, for instance. Even if there's a small amount of hemoglobin, haptoglobin will bind it and become undetectable in your blood because it binds pretty much, all you need is less than 5 or 10 mLs of blood to hemolyze for haptoglobin to become almost undetectable from your system. So it's a very sensitive sort of test to identify if there is even a small amount of hemolysis. The other thing we look for is your red blood cell precursors, or the early red blood cells. They're called reticulocytes. Okay, they're the ones that are being produced from the bone marrow, and then they become red blood cells eventually. Typically, because autoimmune hemolytic anemias are conditions where you have red blood cell breakdown, typically there's a lot more of these reticulocytes being produced because there's signal from the body saying, I'm anemic, I'm tired, there's not enough red cells carrying oxygen to my blood, in my blood to my brain, and so forth. And so these signals go to your bone marrow, which is where various types of blood cells are produced, and these cells then are told to make more, okay? So make more reticulocytes so you can have more red blood cells and so forth. So that's sort of the cycle. And so you oftentimes see high reticulocyte counts in autoimmune hemolytic anemias. And then the most important test, probably the test that sort of helps distinguish between autoimmune and non-autoimmune hemolytic anemias, right, is something called the DAT, or the Coombs test, okay? The direct antiglobulin test, or the Coombs test. And what this test does is it basically picks up any, and it's an age-old test. It's been around since the 30s, okay? And it's one of the tests that we blood bankers, I wear two hats. So, I go to the blood bank in the mornings and I review these results. I was telling Dr. Irina earlier, I look at these DATs and say, hey, who might have autoimmune phenomena? And then go back and look at their chart to see if they have anemias, for instance. So this is actually a very classic test to tell us if there are antibodies binding the red cells. Now, there can be various reasons for antibodies. Those antibodies, it doesn't tell you if those are autoantibodies, which means is your body producing the antibodies, or is it, well, they are antibodies that your body is producing, but it could also be antibodies that your body is producing against foreign red cells, okay, real foreign red cells, as opposed to your own red cells. So the DAT will not tell you if this is an antibody that's being produced to a transfused product or if it's to your own red cells. Unfortunately, in autoimmune hemolytic anemias, these antibodies that you produce will not only bind to your own red cells, it will also bind to transfused red cells, which is why your transfused red cells will also not survive, right? And that's where the thing of transfuse very judiciously, don't give you too much blood because it's going to anyway be destroyed. It's going to add to some of those hemolytic phenomena that we see. Okay, so that's sort of the broad overview of autoimmune, basically warm, autoimmune hemolytic anemias. Okay, there are similarities, like I said, this is sort of the overall picture and similarities. The differences between warms and colds, like I said, the big one is the temperature, although in both of them, you can have, there can be warms that also show up or behave like they may react at colder temperatures. There may be colds, which actually the most clinically significant ones act at body temperature. Okay, the other distinguishing factor is the type of antibody. Okay, warms are typically what we call IgG mediated, and colds are typically what we say is IgM, which is a bigger antibody which binds more cells and it activates something called complement, which basically downstream has a lot of these effects on red blood cell breakdown and so forth. Okay, so sort of, lots of jargon there, but it's, the bottom line is there are differences in the antibody type which also help us tell if it is a warm type or a cold type. Warm type, typically patients are younger, their anemias are a lot more severe, and oftentimes, at least initially, they do respond to steroids, high-dose steroids. Now, we all know that that's not the end game with anybody, right? I mean, the recent American Society of Hematology guidelines for ITP tell you that you shouldn't be using steroids for any more than 6 weeks, okay? And now clearly, in a lifetime, okay, over time, now clearly, there's several of us or several of you in the room that know that that's not happening. That's nowhere close to what the reality is, right? And that's the piece. I mean, to this date, there is no FDA-approved treatment for warm autoimmune hemolytic anemia. I think that's one of the biggest reasons that we are here. And that's the piece that I think we should all be working towards to make a difference. With ITP, thankfully now, with immune thrombocytopenia, the platelet counterpart, there's about 4 FDA-approved treatments, or, 4 categories of treatments, and then, many more drugs within each categories. But, so compared to this sister condition, we really need to be making more definitive and stronger strides in the direction of warm autoimmune hemolytic anemia. Now, thankfully for cold agglutinin disease, as you may have heard, there is an FDA-approved drug, sutimlimab, which is available. Now, cold agglutinin disease, I sidetracked there a little bit, but cold agglutinin disease, typically people present when they're slightly older, okay, and their anemias may or may not be as aggressive and as severe as you have in warm autoimmune hemolytic anemias. They kind of hang out in the hemoglobins of 9, 10, not to a point where, they just can't they can't do a marathon, but, they would be able to get up oftentimes and be able to carry out basic activities of daily living, which may not be the case with warm autoimmune hemolytic anemias. In terms of treatments, there are differences. Steroids typically are the frontline therapy for both of these conditions. Rituximab is also used in both conditions, okay? Increasingly, we use rituximab upfront in warm autoimmune hemolytic anemias. With the colds, depending on how severe they're, whether they're transfusion dependent, there are all these different situations, okay? Things like IVIG, plasma exchange, as you all may know or have heard of, not so effective in warm autoimmune hemolytic anemias, maybe to some extent with the colds, okay? Colds, again, there are, as of these, it's difficult to characterize, but colds, increasingly people have identified that there needs to be what we call a B cell clone, which produces a particular type of antibody against the red cells which cause the anemia, okay? And so then there are treatments that are directed against that B cell clone, drugs like bortezomib or, fludarabine. These were some of the older agents. Now, of course, we have agents that target the complement pathway, which is what sutimlimab is. And I think Dr. Irina will tell us more about sort of clinical trials and so forth. So we'll hear more there. So there's, again, differences in treatment and outcomes, right? I mean, with warm autoimmune hemolytic anemias, it's oftentimes a lifelong battle. You're dealing with, an acute course, rarely, in a small fraction of patients, it remits and then you don't see it at all again. And it can be triggered by infection, it can be triggered by, an underlying lymphoma, an autoimmune condition like lupus. Occasionally you can also see it in the setting of post stem cell transplants or, bone marrow transplant patients can develop this. More recently, there are drugs, chemotherapeutic drugs that can cause some of these. And so those are sort of the big differences there. In terms of treatments, I mentioned, some patients respond to steroids, it doesn't come back. And then there's a group that needs steroids, rituximab, maybe one other additional line of therapy. We like a drug called Cellcept or MMF, mycophenolate, which we use quite a bit, along that line. And then it doesn't come back. And then I have patients who just do that, And then every time they have an episode, I have to give them high-dose steroids and then gradually taper, And this is a phenomenon that's, I say that you should use steroids for less than 6 weeks. I have so many patients who unfortunately we cannot do that on. And then there's splenectomy, with ITP, and I learned from my sort of predecessor at the University of Washington. When I was at the NIH, I used to recommend splenectomies a little more, generously than I do these days, especially for immune thrombocytopenia, because Terry Gernsheimer, who taught me at Seattle, Washington, would always say, why would you remove the one organ that works well in your body? Okay? Works just too well, maybe. So, that kind of sat in my head in the sense that, she would always advocate even for clinical trials before you take out an organ. Because once it's gone, first of all, there's risk of infection. You always have to be vaccinated against pneumococcal infections, and so forth. And then the other piece is blood clots. Those are real. I have seen patients with every time take out your spleen, and then they have blood clots, and then you've given them one more problem where you put them on blood thinners, right? That said, though, I will say that warm autoimmune hemolytic anemias do tend to do better than ITP with splenectomies. And the reason for that, obviously, is that splenectomy, with ITP, these days we have at least 6 or 7 different approved drugs that you can use for. Whereas wAIHA, there's 0 at this point. So splenectomy is still pretty high on that list, okay? That's sort of my overview. I'm happy to open it up for questions. Yeah.
Do we have a question?
Yes.
This is a dumb question, but cold autoimmune hemolytic anemia and cold agglutinin disease, are they 100% synonymous, or is there any distinction?
That's a brilliant question. And, I'm going to try to, it's funny because I got asked the same questions, a question I just presented at the highlights of the American Society of Hematology meeting. So one of the top experts brought this question up, and this has been sort of a question in the field forever, basically. And again, I'll use the term idiopathic there. okay? Not completely in context, but the disease is an idiot. No, it's the physicians who are idiots. We don't know, okay? The classifications are somewhat arbitrary in that we define the boundaries for what we think is cold agglutinin disease versus cold agglutinin syndrome, okay? Both of these conditions can have cold-associated immune hemolytic anemia, okay? But the thought is that with cold agglutinin disease, there is a B cell clone, like I said. There is a specific type of B cell that is producing a specific type of antibody which attacks the red cells and it destroys it. They don't seem to have any other, if you dig deeper and deeper, you do a bone marrow biopsy, you may find evidence for this clone. It's not a cancerous clone. It's not associated with a lymphoma or anything. It's just a clone that produces these antibodies, okay? So if that happens, specialists generally tend to refer to it as cold agglutinin disease if it's a finite thing. Okay, if it's more broad, if there is an underlying lymphoma, if there is an underlying infection, if there is, associated with other autoimmune conditions which generate these antibodies, then you tend to refer to it as cold agglutinin syndrome, typically in the context of infections, okay? But again, the distinctions are somewhat arbitrary because everybody has these cold autoimmune hemolytic anemia phenomena. And treatments in some way, even though for many of these clinical trials we exclude these secondary conditions, if you clearly know it was because of an infection, people often question, would this particular therapy work for it, And I don't know if that's necessarily a right thing. Now we do it to protect patients, we want them to be safe, and so we protect patients and not enroll them, for instance, who have, let's say, an underlying CLL or a leukemia or a lymphoma who have these coexisting conditions, initially at least in trials, because we want a population that we can show benefit in, and then if we extend it to some of these other groups, we might be able to make sure that there's no untoward effects or side effects and so forth. So to answer your question, yes and no, there are differences. At a plain clinical level with regard to presentations, they might present very similarly, and then you dig deeper and there might be other reasons for why it's called cold agglutinin disease or syndrome and so forth.
I'm sorry, but the question was the term
Cold agglutinin disease versus cold autoimmune hemolytic anemia.
Yes.
Yeah. Dr. Irina, I don't know if you have any thoughts on this, but I have used it pretty much interchangeably, and the anemia is a phenomenon. Now, again, you can have cold agglutinin disease and not have anemia. You can have compensated hemolysis. Yeah. Yeah.
Yeah, I mean, I can just add that cold autoimmune hemolytic anemia is a general umbrella term, right? Cold agglutinin disease is a specific term which is used to be called idiopathic cold agglutinin disease, and then there's a cold agglutinin syndrome, which is in the setting of lymphoma or infection. So cold autoimmune hemolytic anemia is like an umbrella term for cold agglutinin disease and cold agglutinin syndrome.
Makes sense. Thank you. Yeah.
Hi. Once a patient with warm autoimmune hemolytic anemia has gone through a splenectomy, is there any evidence if they relapse that the medicines such as rituximab or Cellcept work better after a splenectomy?
Not to my knowledge, no. If anything, the further down the therapy lines you go, the less your chances of going into remission. That is something that's known across the board with all of these autoimmune conditions. Yeah.
Thank you. I'm Alan Goldblatt, a patient. I have, I believe, the warm type, but when I went to my hematologist and, of course, went through the prednisone, I always had a negative Coombs test, and for 2 years, still have it. And it's, but my doctor wouldn't go down the path of getting the super Coombs test or more tests, because the whole idea is that, well, as long as it doesn't matter if you have the warm or the cold if you're under the same treatments. But I'm wondering, is there a benefit as a patient to know exactly what you have, and how do you go about getting that diagnosis, or how do you force the medical community to do those deeper testing that's not readily available in from Quest or whatever type of labs that they're working with?
Yeah.
Thank you.
Yeah. No, thank you for that question. I didn't really touch upon what we call Coombs negative warm or cold autoimmune hemolytic anemia, right? And that's a real thing. It happens more often than we think it does. People, the official records say it happens about 3 to 5% of the time, probably a lot more. And most of the time, we oftentimes get false positives and false negative DATs or Coombs test, right? Because it's so, it's one of the most archaic tests, right? There is a tech who literally physically goes there, separates the red cells, warms them up sometimes, separates the red cells from the antibodies, and then literally measures the antibodies against how much binding there is. It's a very physically, they just look at how strong the clotting is. That's as archaic as it gets in the current times, right? But that's the test we rely on. And can it be wrong? The fact that it's repeatedly negative over the course of a year. And I think it's important in these instances, which physicians do consider oftentimes, make sure it's not a nutritional deficiency, make sure you don't have a B12 or a folate deficiency, make sure there's no underlying cancer, make sure there's no underlying autoimmune condition. So you want to be ruling out all of these, make sure other causes of hemolysis are ruled out. You don't want things like DIC or disseminated intravascular coagulation, where there's red cell breakdown. And I'll get back to your question. There's DIC, there's, other conditions like TTP, where there's red cell breakdown and so forth. Because if the DAT is negative, as residents and fellows, we're taught, DAT positive, so anemia, okay? LDH is elevated, there's hemolysis. What do you do next? Get a DAT. If the DAT is negative, go down this path. If the DAT is positive, go down the warm auto, cold auto path, right? So if the DAT is negative, nobody is stopping there to say, hey, that test may not have been right. They just go right down the other pathway, which is where, you start thinking about DIC and all these conditions, and then they label you as having not autoimmune, okay? But you're repeatedly showing signs, and you have probably responded to steroids. That's a pretty big indicator that there is an autoimmune process going on, right? So that's the piece that you want to be focusing on and saying, okay, now that I have shown that I am responding to steroids, which is highly unlikely unless it's an immune type of TTP, even in that case, you would see several other things, low platelets and so forth. But regardless, most centers, as you know, don't do what we call a super Coombs test. And I'll tell you what the super Coombs test is. I do these tests all the time. It's basically the Coombs test, except they take 30 cc's of blood out of you instead of 5 cc's. One of the reasons we do not do super Coombs test in the immediate setting is because in somebody who has a hemoglobin of 5 or 6, I do not want to take out 30 cc's of blood. Okay? That's a big reason. So when a physician, I wear 2 hats, like I said. When I'm in the transfusion medicine department and the hematologist comes to me and says, get me a super Coombs, I'm like, you give me your blood. I'm not taking that patient's blood, okay? That's a lot of sample to take out of a patient. But what I do tell them is once they are stabilized, once their hemoglobins, because your DAT is going to be positive for a long time to come. And if that's the case, I'm okay with you giving me 40 cc's or 30 to 40 cc's of their blood, okay? That's one piece. Because what they do is then they concentrate the red cells, they take out the antibodies because that's just, 40 times as many cells and antibodies, and then once you get that concentrated sample, you can run it and identify more. Now the other piece that's important to know is typical DATs, test for something called IgG, and they test for complement or C3, okay, or complement activation. There are other types of tests where you can test for IgA. That's a type of an immune globulin. You can also specifically test for IgM instead of waiting to see if there is terminal complement activation, for instance. These are all intermediate things that you could do. Now, a lot of these are flow-based assays, a lot of these are send-out assays. I would say as long as your hemoglobin's stable and you have been on extended periods of steroids, it behooves the clinicians to say, I need to take this person off of steroids and I need to know what the answer is. And I would, that's a situation where I would say push for it very strongly.
Thank you.
Mm-hmm.
Yes, ma'am. Is there a connection between the autoimmune and myelodysplasia, or?
That's a difficult question, I have to say. The aplastic anemia, for instance, right? There's myelodysplasia, which is basically the bone marrow making cells that are abnormal, not producing the type of results that they should be. Your red cell precursors are kind of funny, so you're getting anemic. Your platelet precursors are funny, so you're not getting enough platelets, okay? In these situations, and I'll tell you, so can myelodysplastic syndromes coexist with autoimmune phenomena? Certainly they can. I mean, just like anybody over age, myelodysplasia happens with any, if not all of us as we age, okay? And increasingly people are recognizing that over age, your blood cell mutations accumulate over time and your cells start becoming more and more what we call dysplastic, okay? So if you live up to a 90, you might have 30% of your cells or 10-15% of your cells that are starting to look abnormal. It's just, the stem cells have become so tired of replicating that by the time you're 90, they're starting to look funny, okay? So as part of the normal aging process itself, there is some amount of dysplasia